Welcome back to Love and Hustle. I'm Brittany, and this is the podcast where couples, companies, and chaos collide. Today, guys, we are going to be doing a special podcast episode with a guest who is not a photographer and not an entrepreneur, but instead my plastic surgeon. Y'all, this conversation is so good. Whether you have wanted to have a mommy makeover like me, you have considered any type of plastic surgery at any point in your life, or maybe you actually have had a mommy makeover or some sort of breast augmentation. We are talking about all the things around plastic surgery. Everything from the right questions to ask, red flags to look for, as well as how to go into a consultation with the right frame of mind. Dr. G is going to not only be sharing her expertise as a board certified plastic surgeon, she's also going to be going in depth about the emotional sides to plastic surgery, sharing some of her best advice for those who are seeking to have a procedure done for themselves, and also to some of the misconceptions and hot topics in and around the plastic surgery space. So let's jump in to this awesome episode with Dr. Giardo. I am so excited to have Dr. Giarda. Am I saying it right?
You're very close. It's like the male name Gerard and then add an O at the end.
Gerardo.
There you go. It's perfect.
It's funny because I feel like if I wasn't thinking about it, I'd say it right.
I know. Everyone tries really hard and it's very normal. Not many people can get it right. So G is fine.
Dr. G, yeah. And that's kind of how I like every time I write an appointment, I'm like, Dr. G.
So, you wouldn't be the first.
Well, thank you so much for joining us today.
Thank you for having me. This is so fun.
I am so excited because we obviously have recorded a couple of episodes, but it's really fun to bring it full circle. And I think because of my background as a nurse and then Zach's background as a pharmacist, it's really fun to get to have somebody like in the profession sharing their knowledge because we know how powerful that is. And yeah, I'm really excited for the listeners. Well, before we get started, can you share with us a little bit about your credentialing and how long you've been doing plastic surgery?
So I am a board certified plastic surgeon by the American Board of Plastic Surgery. I've been a physician now for 10 years, and I did 6 total years of plastic surgical training. I've been board certified now for 2 years, which is right after I finished residency.
Wow, that's amazing. I know. Zach and I were like, how old do we think Dr. G is? Because you look a lot younger than you really are.
Man, you're just trying to flatter me. It's all Botox, right? And never seeing the sun.
Right. Well, yes. Yes, for sure. Yeah. Because I feel like, too, you like understand what's going to really cause aging. So you've been probably more diligent about it than most of us have.
I sure hope so. But the amount of Diet Coke I drink, I don't know.
Yeah. And so you didn't plan, I saw you sharing about like your journey didn't start with plastics. When you were like originally going into med school, you didn't see this path for yourself. When did that come about?
So I actually wanted to be an orthopedic surgeon, so fixing fractures and things like that. And one of my physicians told me that I was a terrible suturer, and I was determined to get really good. So I did a plastics rotation just to make sure that I could kind of up the ante, and I realized, oh my gosh, this is incredible. It's a mix of science and art together.
Yeah.
And I was hooked ever since.
I love that. That's so cool. I know. So my mom worked in orthopedics, and just seeing, there's a lot of things that like when I was a nurse that I was like, I was cool with. But like eyeballs, and anytime there was like bone involved, I was out. I was like, nope, nope. Okay, well, I'm so excited. So today's episode, we are going to be talking all about mommy makeovers, breast augmentations, breast lifts, tummy tucks, basically all of the things that us as women are really thinking about. And I was really attracted to your work because you have a very natural, approach to your style. Would you say that like plastic surgeons have like styles?
Absolutely. I think that surgeons attract certain patient demographics based on the before and afters that they provide or post. And my biggest focus is natural results and surgery that complements your natural beauty, but doesn't, overdo it. You don't have the surgery to walk in the room before you do.
Yeah. Oh my gosh, that's such a good way to put it. And I will say, even the times when you share stuff and you're like, this client wanted a really augmented look, I'm like, but it's still tasteful. Like it's still done well in a way that like you can tell that it's I'm not.
Boom.
Yeah, like you can tell it's not natural, but it's done in a way that just like still fits their body. Okay, so we'll just jump right in, and I have a slew of questions, and not only did I post on Instagram and have people chime in, which by the way, so many people follow you and love you, and there's several people who follow me and have had work done by you, which was really cool to see. But I also went into a Facebook group and kind of just like have been pulling, just like seeing like really common questions.
Sure.
And I actually shared one of I shared a little results photo.
Ooh,
and somebody has a surgery with you in June, and she's like, I can't wait to listen to this podcast, and seeing your results is affirmation I picked the right surgeon.
That's super exciting.
Yeah.
Thank you for sharing that.
So first let's talk about the under the muscle, over the muscle, because I saw you even share something recently that was very informative, just talking about just different implants and how they're placed. Is there like a preferred methodology for you, or like what plays into the decision of if it's going to go under the muscle or over the muscle?
It's a really great question, and it's a complex one. But majority of my patients, I do what's called a dual plane technique, where it's under the muscle on top of the breast, but under the breast tissue at the bottom, which is the way that yours was done. But what this does is provides really nice implant coverage at the top of the breast, so it looks very natural, not too harsh or round of a look. And then the lower part of the breast sits and moves naturally. Subfascial or subglandular breast augmentation is when the implant is placed under the breast tissue itself.
Okay.
This is good in certain patients that have really good skin quality and don't necessarily want a bigger implant or don't need a lift, things like that.
Okay. And is this dual plane technique, is that something that like you would say is like newer, or has it been around a while?
It's
just like
been around a very long time. I would say it's probably the most common way done in the United States and at least South America. I'm not sure about Europe. It's been around the longest.
And is there like how do you decide placement? Is it just the technique? I'm sure there's certain things where it's just like you have a way that you probably feel most comfortable doing things, but is there times that you have to sort of stray outside of that based on the results?
So it's always a collaborative approach. If a patient is really strongly, wanting to do subfascial, we'll certainly talk about the pros and cons of each different type of surgery. I find that for longer lasting results, at least in my hands, I find that dual plane provides a longer lasting coverage of the implant, less rippling, less visibility of the edges. And so it's more predictable. Whereas subfascial, as we age, so does the breast tissue. It starts to relax. And sometimes, unfortunately, we can start seeing the ripples of the implant at the bottom as time goes on. So maybe not necessarily immediately, but it ages a little quicker.
Okay. Yeah. I definitely feel like too, I've known people, and seen that progression for sure with like aging. So when it comes to choosing implant size, and this is something that is so fascinating to me, because when I obviously went through several consultations, and it was a variety, which I recorded an episode where I talked about how each doctor had a very different approach. And like one had me trying on sizers, and I was like, I have like a pretty decent size deflated breast, but I had one. And I was like, I just am struggling. Like this just wasn't really, I don't know, putting a t-shirt on with like an implant wedged in my bra just wasn't, I think, helping me, if that makes sense.
It can almost confuse the process.
Yeah. And I actually saw that there's like 3D, you can have like a 3D rendering of you. And then I saw somebody put on Meta glasses.
That's cool.
Or Meta or VR, VR. And they got to look down and see there. And then they changed. I think this doctor had two different options like for her or something. I don't know, but she was able to see what she was kind of torn between. I thought that was so cool. But when it comes to sizes, it's been really fascinating to be in this Facebook group, just kind of watching from the sidelines, because people are like, I told my doctor that I wanted 600 cc's and I only got 400. And I'm like, you didn't really say, like, what size would you like? Like, I just felt like, it was funny. I was talking to a girlfriend of mine, and she's like, I mean, it sounds like they're going through a drive-through and they're like placing an order for like what size burger they want. Like it's wild to me that I just like listen to you as the professional, and I'm like, this is how I hope to look. What's going to get me there? You know, the idea of a size to me just seems really confusing and not fully understood. And so, do you feel that patients should come in with a specific size in mind, or like what do you feel is the best approach?
It's a really great question because I think it's probably the most difficult for patients to understand. But coming in for me with inspiration photos is the most helpful because it helps me see how close you want your cleavage, how much fullness you want at the top of the breast. Do you want a little bit of side breast? Do you like something a little bit more natural or more augmented? And so it helps me kind of get as close as reading your mind as possible. When patients have friends or Facebook groups, things like that, where they kind of get convinced they need a certain size, that's when we get into trouble. Unfortunately, we're all built so differently, and that's what makes plastic surgery such an amazing art. But you and your friend have very different measurements. They're never going to be the same. And your bone structure is different. Women, some women have a chest wall that has asymmetry, or one side is bigger than the other. And coming in with a preconceived idea of what's appropriate sometimes can backfire and give you a result that doesn't look like the pictures you want.
Yeah, I felt like the approach of pictures made so much more sense because as I moved through the process, I realized that it's so subjective. And what is like considered full or large to one person isn't to another. And what is 300 cc's on one person is completely different on another. And so as I've watched and, kind of just observing people going through this, I've been like, I feel like the inspiration photo definitely makes the most sense to me.
It's not about a CC, it's about your anatomy and your goals. And I 100% agree. If you come in with this preconceived notion, everyone's idea of natural is different. Everyone says they want natural, but your natural and my natural is going to be different. And so it's all about what you want and what makes sense for your body.
I love that. Can you walk us through what choosing an implant size looks like in the OR?
Sure, that's a great question. So initially we take measurements at your preoperative consultation. These kind of tell me where we're symmetric and where we're not to start with. So we have a kind of determined range of implant sizes that we'll use. When I go into the operating room, I'll make the pocket based on your chest width and your desired look. And then once I've created the pocket, I actually put in a saline inflatable sizer that I'll slowly inflate with saline within the range of what we've discussed. So let's just say, for example, we talked about 300 to 400 cc's. I'll start at 300 cc's and see what looks best. And sometimes that's 375, sometimes that's 320. It just depends on what in real time fits like a glove on your body. And I'll make small adjustments to the pocket to, maybe give you a little bit more subtle side breast, or perhaps make the top of the pocket tighter if you want a more augmented look, things like that. So a lot more goes into it than just, the dimensions of the implant.
That's like so interesting. And I heard people using the verbiage like pocket work. And what does like pocket work mean exactly?
It's a really good question. I'm trying to think of it in the best way, like lay terms. Essentially, when we're putting in an implant, we want it to fit like a glove. We want it to fit inside the pocket, but not have too much loose space and not be too tight. You want it to move naturally. So pocket work is when we go in and we create kind of that mold that the implant sits in. And that's kind of where the real artistry, earlier you talked about good versus a great result. That's where you take a good result to a great result, is making the pocket very, very intricate based on your anatomy and your goals.
So so I actually have had several people ask me about my implants, my implant size. And I had asymmetry, which I had slight asymmetry before I breastfed, but it got more so after I breastfed. I definitely had a side that my kids preferred, and all four of my kids preferred one particular side. And I'm sure all the moms are like, yes. I actually had a friend who had one of her babies just wouldn't nurse on one side.
Oh,
I don't know if there was like some sort of like torticollis or something, like some sort of, and she was like she's probably spent like a good year and a half being like visually completely different sizes, like 2 completely different cup sizes.
Yeah, she's a very good mom. That's tough to deal with.
Yeah. Well, and the other thing too is just like such a testament to the strength of our bodies, because her one side was able to, produce enough to feed that baby.
Right.
But when it comes to asymmetry, this is like fairly normal, would you say? Like most.
I have never had a single patient come in that's completely symmetric. No one.
And I'm sure once you start doing all of those measurements too, you start to like, where visually at a glance it might look symmetrical, but then once you really start to measure, you're like, oh, okay, there's actually,
Yes.
okay. But why would someone, need different implant sizes if, like in my case, where you were doing a reduction, or I should say a lift, which would you classify what I had as like?
I did a small reduction on the bigger side.
Okay.
And used a smaller implant, and then didn't do a reduction, did a lift on the bigger side and or on the smaller side, and then did a bigger implant. So to balance things out.
Okay. Yeah, because I just am sitting here and I'm like, and now that I hear you say that, you're like a reduction and a lift, and I'm like thinking about the whole pocket scenario.
Yes.
And I'm like, okay, now you guys see how complicated this is.
There's a reason it takes 20 odd years to become a physician, and plastic surgeon. It just takes a long time. But,
yeah.
In your particular case, like you said, one breast was a little bit larger before having kids, and then breastfeeding kind of compounded that effect. And it's very common. And so in your particular case, the left side was slightly larger and sat a little bit lower. And so we want to get symmetry at the end. It doesn't matter what the numbers are. It matters what it looks like, and it's balanced. And so I like to balance not only the implant size, but also how much tissue you have. And because you had more tissue on the left-hand side, I took a little bit more away from there so that they'll age the same. So, different sizes, but similar amounts of tissue left over.
I think that's too, like, where I'm like, I had questions. I was like, what will this look like as they start to heal and as I, start to live in them, so to speak, or they start to live in me? Will they still look symmetrical? And I would say I've asked Zach several times, I'm like, are they the same? Are they the same? Are they the same?
We all
and
do
he's
this.
like, I can't, I don't have anything for you. He's just like, they're the same. They're the same. Okay. So here's the part that was really interesting for me is I saw 4 different surgeons, all board certified plastic surgeons. And I had 2 tell me I did not need a lift, and I had 2 tell me that I did. And the one that also said I needed a lift, did talk to me about how like he would match my incisions, and kind of like, I think it sounds like similar, because that was one of my questions. I was like, you're just going to lift one and not the other. And then I'm going to look like, you just imagine like, how is that going to visually look? Sure. But then there were 2 that said I didn't need a lift. And I remember by the time I had my consult with you, I'd at least gotten enough information to have very clear, like, I wanted to ask you. And you said very clearly, for the results you want, you need a lift. Knowing what those other surgeons know or what you see in practice, like, what would be the circumstances? Like, what would my results have looked like, or what would have happened if I had not gone with a lift?
So it's a great question. In my opinion, with your particular case, you wanted to have higher, perkier breasts that look like your prior breasts, but you didn't want to go substantially bigger. When we have a little bit of, droopiness of the breast that we're trying to make, more perky, using a bigger implant can help sometimes, falsely lift the breast. But in your case, you didn't want a really big implant. You wanted to look like yourself, just more youthful. And so unfortunately, it's a lot easier just to do a breast augmentation than to do a breast augmentation and lift. It's a lot more complicated. And for some surgeons, they get better results doing a bigger implant and skipping the lift.
Yeah. I knew like that I wanted to like get that clear answer, because the thought of the scars was like hard. But then I started to think about, well, what's it going to be like in 10 years? And then I have these implants, like, and I actually asked, and they said, well, then you'll just get a lift. And I'm like,
so we're gonna do this again?
like, yeah. So then I'm like, wait, so then I'm just going to be back here in like 5 to 10 years, just getting what I think that, So anyways, I found that to be just such an interesting interesting scenario. And it seems like when you're on the cusp, it can be really confusing as the patient. Is there anything that you feel that a patient in those types of scenarios should like really ask or like clarify?
Sure. So my standpoint on it is it's always better to have a great shaped breast than, try and minimize and make scars smaller, because we know how to make scars really fine line and pretty, but if the breast shape is off, then the whole result, isn't attractive. So when a patient comes in and they're kind of on the cusp, particularly when we have asymmetry, it wouldn't make sense to do a lift on one side and do just an implant on the other, because then the human eye is drawn to the differences in the incisions. Your eye automatically goes to, what's different. And so you need to harmonize the result. So if one side needs a lift, I almost always do a lift on the other side for symmetry.
Gotcha. And if someone were who like needs a lift, but then skips that part, what?
I hate this one. It's so hard because nobody wants a lift, right? I mean, I don't want to have a lift, but I know I will someday. But when you get implants, when your breasts are too saggy and, there's just not enough implant to fill that space, it's almost like taking a garment that's been stretched out and then just trying to stuff it full of something. Mm-hmm. You're still going to have the same shape, just full. So we get kind of a tuberous or tubular breast structure, and I don't find that visually attractive or youthful. Some patients do opt for that option, but I make sure I review extensively what they will get with that result versus what they won't get, and I'm very clear about that.
That's so helpful. I do feel like you were very, very clear about like results, which is so awesome. It gives the patients a lot of confidence in you. So when it comes to sensation and breastfeeding, I know that breastfeeding will probably be a topic that's amongst the ears for the moms who maybe those listening who haven't had babies yet and want to have babies. What can you share in the way of like, if they wanted to have a breast augmentation or even a breast lift, like how does each scenario impact the ability to breastfeed?
That's a great question. In my case with my surgeries, any breast surgery I perform, you should still have the ability to have nipple sensation and milk production. The only times I see there's a heightened risk of decreased sensation or ability to breastfeed is when a patient has really large breasts and we're doing a very large reduction. We're talking J's, K's.
Okay.
And so we have to take away so much of that tissue, it kind of changes your natural anatomy.
Yeah.
With an augmentation or an augmentation and lift, you certainly can still breastfeed. Maybe just have a slightly decreased supply compared to what it would have been prior to surgery.
Yeah. I have so many friends who have had breast augmentations and have successfully breastfed their babies for as long as they had hoped, for sure. So, and so that's really interesting to hear about nipple sensation. What would cause someone like when someone loses sensation in their nipple, which I've heard that's like, I know people who have.
Sure.
What is that caused from?
It's typically due to the technique or anatomy of that particular patient. So let's say the patient had extra tissue maybe around the areolar nipple that needed to be reduced. It's closer to the nerves, right? And so your anatomy kind of dictates your results in a certain way when it comes to sensation. So depending on how the breast needs to be shaped, it can increase the risk of that.
That's super interesting. So when it comes to implant type, which this is so also really fascinating to me because I've seen people who have requested, like in groups, they're like, I want a Motiva implant, ergo, whatever. I knew nothing. Like I came to you and I didn't know, like, of course I had heard of like Allergan and like I've heard of like lots of these manufacturers, but I had no idea what was what. I do love that, you guys gave me like a pamphlet that like walks you through like what is a moderate profile? What is a low? What is a high? Like it really just informed me a lot on what the choices were. But when it comes to choosing, how do you decide? Because you guys do have like several options.
We do. So all of our implants that we offer are silicone gummy bear implants, which means that the gel is a gel that stays together if you were to cut through it like a gummy bear. These are the most natural feeling and safest, most durable. So that, to kind of start off, I only use silicone gummy bear. There are saline implants. I find that they have more rippling, more visibility, and they can spontaneously deflate like a flat tire. And so it's something that I never found to be aesthetically superior to the silicone. So as far as profiles, that's a collaborative approach with me and with the patient and I, going over their goals and discussing, how do you feel about this size? How do you feel about this profile based on what we've discussed?
Yeah. I remember the day of surgery, you were like, well, I was kind of thinking, maybe we go high profile. And I was like, I just want to look natural. Like, I was like so scared of that. And now that I feel like I'm on the other side, I was like, okay, I feel like if that had been the decision made, I probably would have trusted you. But I definitely, I was like afraid of that word high profile. Yes. I was like, no, that way. So
many people come in saying, I don't want high profile or full profile. So that's understandable. I find that for patients having a lift, it's more common to use the high profile, at least in my hands, because it gives you kind of guaranteed upper pole fullness. You had natural breast tissue, which is great. So you already had, tissue in that area where a lot of women are just completely deflated after breastfeeding. And so we need that projection to really kind of make things perkier.
And do you find that because the implants, when they first go in, they're kind of shaped, like a half a coconut, right? Yes. And then they start to slowly, like they say, drop and fluff, and they kind of slightly slope down more natural. Does that still happen in a high profile implant the way it would in like a moderate or a low?
Yes. So the drop and fluff process is the same. Kind of the best way I describe it is that if your implant is under the muscle on top and your muscle's all swollen, it's, bruised and it's kind of up here. At first it looks really boxy and kind of strange. It can be a little bit alarming. But as that muscle relaxes its grip on the implant, it settles down into that breast tissue at the base of the breast. And so that's when we get the nice slope on top and that teardrop appearance at the bottom, because the muscle's pushing on the top of the implant. It's kind of making that natural teardrop.
Okay, that totally makes more sense now that you explained that. I have seen this. I saw in a group called Frankenboob.
Oh my.
Yes. It's like a common term in this. Yes. I'm like opening your eyes. You should not join this group. You would probably
no. I gotta stay away. I recommend staying away from until after you're done with surgery.
I did not. I think I joined maybe a week before. I didn't post anything, or I just started to quietly observe. And it was a great pastime, when I was on bed rest after my tummy tuck.
I've seen some interesting screenshots from these things. I'm personally not in them, but patients will be like, I really don't want this belly button. I'm like, I really don't want that belly button,
Yeah.
I think I have necrosis and it's just a scab,
Yeah.
And I'm like, where did you hear that word? And they're like, well, on my, Facebook group, this one lady said that she had necrosis and that mine looked like that. And I'm like, no.
Oh,
we just need some Aquaphor and you'll be good.
Yeah. Oh, no, my gosh.
It can cause heightened anxiety.
Yeah. Oh, 100%. Yeah, absolutely. So when it comes to incision placement, because obviously I will say that your comment about the scars, I think is so accurate, because there is so much you can do for scars. But when it comes to the incision, you're obviously going to choose the incision for the best result. Is there one that you find you use more often?
So I guess it depends on the procedure and the patient. For an augmentation, I almost always use an incision under the fold of the breast that's 2 inches long. For, there's some surgeons who do it through the armpit or through the areola, but this is a higher risk of complications doing it that way, so I just don't offer it typically. When it comes to a breast lift, that's dependent on how much kind of, sag or droopiness of the breast is there. When we think of an anchor pattern versus a lollipop, have you heard of those?
Yes.
Okay, cool. So if you can think of it this way, the vertical incision that goes up and down, that's going to make the breast more narrow, okay? Mm-hmm. And the horizontal incision in the fold is going to lift the breast. So it's going to reduce the tissue in the, horizontal plane or in the vertical plane. So if you pinch your breast upward and you lift it, you kind of know that you're going to need that anchor pattern in order to get what you want. It doesn't just kind of go that way. A lollipop lift works in small instances where there's not too much droop, and we just need a little bit of tightening of the sides of the breast.
Gotcha. So as far as lifestyle, how and the long-term goals, like does that get factored into the decision too? Like whether, like someone's super athletic, or is there any type of decision process being made, in and around the implant or the incision based on like what this person does professionally or anything like that?
So it does vary. If someone's a competition power lifter per se, right? They're being judged on, their pec, shoulder muscles. That's probably a good person to do subfascial if they're a candidate, because they're really going to be using muscles that aren't necessarily going to make the breast look good over time. The majority of women, it doesn't matter what, exercises you do, Pilates, CrossFit, you can have it under the muscle and have a great result and still do all of the things that you want to do without having what's called animation deformity. Have you heard of that?
Mm-mm.
Animation deformity is what a lot of women are afraid of with under the muscle dual plane. It's when the implant kind of moves when your pec muscles move.
Oh, okay.
Yeah.
Yeah.
When done correctly, this isn't an issue. I have patients that are aerial acrobats, yoga instructors, all kinds of things, and they can still do all their activities with their implants being under the muscle and they don't move.
That's really interesting though about like being a power lifter, because like I can totally see how that would
Yes.
that would play
Usually they need
decision.
mesh too, so it's a whole different ballgame for those patients. But again, important to customize, based on them, and that's something that we'll go over extensively. What do you like to do for fun? What kind of exercise do you do? Do you plan on having more kids? These are all factors that play into the plan to make sure that you get the best surgery for what your lifestyle looks like.
So let's talk about fat transfer for a second. Is that something you guys offer or that you do?
We do. Fat transfer is tricky. It sounds great, right? Using your own tissue to augment the breast. It works exceptionally well in breast cancer patients who've had a mastectomy and their breast tissue has been removed and they have an implant that kind of can't be hidden well. So it's used to camouflage the implant. The reason I typically don't use fat transfer in my practice is because only about 60% of the fat that I inject will survive. That's, all surgeons combined. And so the fat that doesn't survive can sometimes make little pea-sized nodules throughout the breast. I had a patient come in last week who had little pea-sized nodules all over. And that can be really anxiety provoking for patients, finding a new mass in the breast.
Oh yeah.
Having to get, extra mammograms and sometimes extra biopsies. So for me personally, I find it few and far between for patients to be okay with that and kind of, comfortable with that long term. It almost feels like a marbles under the skin. It's so you can't see it, but it definitely can feel it. Definitely on a mammogram, it'll look like BBs kind of scattered throughout the breast. Yeah.
Oh wow.
The radiologists do not love it, but I think a lot of people think that fat transfer is kind of, and just pump it up, like a tire, where it's more like using primer for your makeup. It fills in some of the potholes, fills in some of the pores. It's a nice smoothing effect, but it's not going to change your bone structure. It's not going to, completely change your look. So that's kind of how I think of fat transfer. It's great for small areas where we want to change the contour or enhance the contour, or for women who want a really small incremental change in the breast volume.
Gotcha. So let's now pivot and talk a little bit about tummy tucks and core repair or diastasis recti. I had what you would call a full tummy tuck, right?
Yes. Correct.
And so can you first share for those listening, what exactly is diastasis recti?
So diastasis is when the two abdominal rectus muscles, or your six pack, separate due to the pressure of the pregnancy. So there's a thin layer of fascia between them that kind of keeps them together. And so during the pregnancy, that starts to splay outwards. And so when that happens, you lose core strength, you lose the ability to kind of suck in the abdomen like you normally would, and it can cause low back pain, all kinds of issues. This doesn't always happen during pregnancy. Some patients, it's more genetically, common than others, but making sure that you have good pelvic strength and core strength prior to pregnancy as well as after can help reduce this.
Is there like obviously from pregnancy, can people experience this even if they haven't been pregnant?
Very rarely. In a sense, a hernia is kind of like a diastasis. So some hernias do cause that, or if there's a mass within the abdomen that's expansive, that can cause it over time, but very unusual.
Yeah, I think that I'll say that like, I think after having experienced this, one, I will say my OB did not assess me for this. I never really had like a full abdominal assessment or any sort of like, hey, you should consider, any type of, honestly, there was really nothing in the way of like, it was just like, hey, you've had a baby. Let's just make sure you're feeling okay.
Right.
There was not,
It's not the focus.
there was definitely not anything around like, my pelvic floor health or my abdominal health in that sense. But I do think there's like this false belief that women can restore it with working out. Can you share a little bit about that?
That's kind of one of the frustrating myths surrounding it, is that you could be the most athletic, fit, healthy person, but if you've had a large pregnancy and the muscles separate, there's no way for you to work that out to make it better or fix it. Once it's done, it's done. And so this can be super frustrating for women, feeling like they're doing all the things, they're working out, they're eating healthy, and they still feel like they're pregnant. They still feel bloated and kind of poochy. And so it's really important that people understand some small degrees can be corrected with physical therapy and things like that. But the majority, once it's kind of past 2 finger breadths wide, there's no way. And so you have to have surgery to repair that anatomy and bring it together.
Now walk us through like, and I'm really curious too for my own, walk us through like what that looks like. I know you had talked about, I had asked you about a mini tuck. Mm-hmm. And you were the only person that said that you could do repair with the mini tuck.
Can be done. It's not a full repair, and there's some downsides to it. Mini tummy tuck only works when you only have laxity in the lower abdomen. You had a great abdomen to start with, but you did have diastasis both above and below the belly button. So if I tighten up the lower abdomen only and fix the diastasis there, but don't tighten up the upper abdomen, then you get kind of a pooch up there, which is not desirable either. So it kind of it's a partial fix. It's not a great fix for the entire abdomen.
It is not like the best aesthetic outcome. No. And I know that that's where you were like, aesthetically a full tummy tuck is going to be the best result.
And also too, I think a lot of times the shape with a mini is not great, because imagine if the incision's this long, it has to be straight, right? Maybe a little curved. Uh-huh. So you're just pulling skin down. That gives you a really boxy appearance. Doesn't matter how much lipo I do if the skin is going straight down. Whereas when we have that nice curved, bikini line incision, I can bring in the waistline and bring it down inward so that you have that feminine shape. If I pull it all straight down, it just looks like, belt and suspenders. It's not a feminine, natural look a lot of times.
Yeah, I didn't, like, going into this, I did not have any idea. Like, I actually, once I was in the process, I kept seeing like the triangles of the removal of the skin. And then it finally clicked to me that you're literally removing from the like top of the belly button to the incision line.
It's pretty shocking.
Yeah. And it's like, I didn't know that how in depth that was. And then I was like, okay, this all makes sense now. I completely understand. Can you explain, because I never even fully understood when there's a vertical incision?
Yes. So it's rare that I use them. It's typically used when a patient's quite thin and doesn't have much loose skin. So you would kind of obviously fall in that category. You had a great abdomen. But when we go to cut the extra skin out, if there's not enough skin to kind of reach the bottom, sometimes the area where we took your belly button out before, like where we cut around the belly button to move it, is still present. And so we have to close your old belly button opening. And so that's down there. There are surgeons who will do a vertical to make it a little bit kind of tighter at the bottom. I personally don't feel that helps my result to do other things to tighten it more at the bottom.
It is like truly, like as you explain it, it's almost like being a sculptor with like, but it's a person and they're obviously their anatomy. You're not like at this, you have to work with what you have. So I think also sort of going into weight loss and the GLP-1s my husband's a pharmacist. He actually dispenses more GLP-1s now, I believe, than like any other.
You're kidding.
Yes.
Wow.
He can actually give statistics on it. It's pretty wild.
That is.
And I mean, now, I mean, the GLP-1 space in the pharmaceutical world is just like booming. And so it's really interesting to be kind of have that like pulse on what's happening over there. But from your perspective, should someone who's on a GLP-1 wait until their weight has stabilized before they do surgery? Like at what point would the right time be for them?
Yes, so we see this more and more often. The patients are being really successful with their weight loss on these medications, which is great, but they're not done yet. They're still kind of getting to goal. And so I always recommend getting to your goal weight completely and then being at that weight for 3 to 6 months, ideally 6 months. The reason being is imagine I do a tummy tuck. I've got your muscles repaired again. I've removed the extra skin and you're like, man, I look great. I feel great. I'm going to go to the gym more often now that I don't have to lose skin. And I'm going to lose another 20 pounds. That's when we get the skin laxity that comes back. And we want you to have an awesome result first time and last time. But if our weight yo-yos too much, we can't control that with one surgery. We can't control the change in the skin.
So this is, I totally thought I wanted to ask about this. Have you ever had a patient get pregnant after a full tummy tuck?
Yes.
And so what happens when the abdomen's been repaired and like surgically the diastasis has been repaired?
So it's completely safe. I do use an absorbable suture to do my corset, the internal corset. And so it dissolves with a corset 6 months to 9 months. So if you were to get pregnant after surgery, your abdomen will expand naturally as it would. It's not going to restrict growth of the baby or anything like that, but you may lose your diastasis repair.
Okay, so now I'm like asking, so if they're dissolvable, what happens after they dissolve in my case? Because I'm not having more babies.
So your own body forms scar tissue and the fascia scars back together. And so you don't need the suture forever. You don't want permanent material you don't need in your body. And so what it does is it basically creates a scar line that's 3 layered in my case. And so by the time, it's dissolved at 9 months or so, there's no need for it. It's kind of superfluous.
Yeah. And so in the case of like being pregnant, it's just really like the baby is really pushing apart the scar tissue, not necessarily pushing not like tearing sutures inside you.
My surgical tech Z, she's awesome. She has 4 kids and she had a tummy tuck right before her last pregnancy. I mean, she got pregnant nearly immediately after, and that happens. You're feeling really good about yourself. Yeah. You're feeling sexy again. So it is common. And surprisingly enough, even though she had a really large pregnancy that time, her abdomen looks great still. I mean, her diastasis is still together. So I think it really depends on the patient. Are they overweight? Are they fit? That kind of thing. And if they, gave themselves enough time to heal before they got pregnant again.
Yeah. Zach's like, oh shit. I'm so joking. I joked about having a 5th baby for like a really long time, but I actually was telling him over the weekend, I knew I was done. There was a part of me that I would see. I remember when I hadn't had Lukey yet, our last baby, and I would see another baby and I'd be like, oh, I want that. Or I'd see him on breastfeeding and it'd be like, I would start to cry. Honestly, I'd start to tear up. And then this weekend, we actually only had Lukey. All the other kids were playing with friends, and we got to go to a restaurant, and I saw this mom breastfeeding in the middle of like all of these soccer tournaments, like craziness. And I just looked at her and I was like, God, I don't miss that. And then we got home and I was like, when are you getting a vasectomy?
Oh my gosh.
But part of me is like, I don't want to ruin all your beautiful work. And like, honestly, like I feel like my body's never been prettier in my life. And so I just can't imagine getting pregnant and
going stunning as is before surgery. And, I'm so glad that you feel so confident now afterwards. But the good news is God forbid it happened. It's fixable, it's not ideal.
So somebody who maybe has experience, like who's gone through GLP-1s and has had weight loss, but hasn't had a child yet, they could, in theory, have a tummy tuck and get pregnant.
Absolutely.
Hey y'all, this episode has been so good with Dr. G that we're actually gonna make it into a 2-part series. If you guys are enjoying this conversation, you are going to want to be sure to come back for part 2, because we're going to be going in depth on some of the controversial topics within the plastic surgery space. Dr. G is going to be sharing some of her patients' biggest regrets and some of her best advice for those who are seeking a mommy makeover. Stay tuned. Join us for part 2.